Okay, in cancer care, you're faced with this clinical mystery all the time. A patient's platelet count suddenly takes a nosedive. It's a really critical situation, and today we're going to approach it like detectives to crack the case, figure out why it's happening, and exactly what to do next.
So you get that lab report, and boom, your patient's platelet count has plummeted. You know you've got to act fast, but the very first step is to answer that one crucial question. Who's the culprit here? Is it the treatment we're giving? Is it the cancer itself? Or is it something more sinister, like a misguided attack from the body's own immune system?
Well, the good news is there's a really logical framework for this, and over the next few minutes, we're going to build that framework together. I'm going to give you a clear path to solve this clinical mystery, every single time.
Okay, first things first, let's do a quick briefing on our key player, platelets. Thrombocytopenia is just a fancy way of saying you don't have enough of them. Now, they're made in the bone marrow, they're absolutely vital for clotting, but here's the kicker. They only live for about a week to 10 days. And that short lifespan is so important because it means any disruption, whether it's to production or their survival, is going to show up as a low count, and it's going to show up fast.
So, like any good detective, our first move is to line up the main suspects. In this particular mystery, there are really three primary culprits we need to investigate. So let's dive in and start examining the evidence for each one.
Our first and by far our most common suspect is the treatment itself. We call it chemotherapy-induced thrombocytopenia, or CIT. Honestly, this is the one you're going to see day in and day out in oncology.
So how does it work? Well, the mechanism is really just collateral damage. Chemo is designed to kill rapidly dividing cancer cells, right? But that also includes the platelet factories, these cells called megakaryocytes in the bone marrow. Now, the biggest clue, the absolute smoking gun for CIT, is the timing. You're going to see that platelet count hit rock bottom, what we call the nadir, about 1 to 2 weeks after a chemo cycle. And because chemo isn't picky, you'll often see a drop in white blood cells, neutropenia, right along with it.
And this case file? It's a perfect example. We've got a patient on carboplatin, a drug that's notorious for this. And right on cue, on day 10, smack in the middle of that 7 to 14-day window, her platelets drop. That is a textbook pattern for CIT. Suspect number 1 is looking very, very guilty.
All right, let's move on to our second suspect. Sometimes the problem isn't the treatment we're giving, but the disease itself. This is what we call bone marrow infiltration.
What's happening here is that the cancer cells are literally crowding out the healthy marrow. They're staging a hostile takeover and shutting down the entire factory. The biggest clue for this is that it's not just the platelets that are low. You'll see what's called pancytopenia, a drop in platelets, red blood cells, and white blood cells. And if you look at the blood smear, you might even find more fingerprints, like these really distinctive teardrop-shaped cells.
And you can really see the difference in this case file, can't you? The patient has low numbers across the board: platelets, red cells, white cells. This isn't an isolated hit like we saw with the chemo. This points to a systemic failure of the entire bone marrow factory because it's just being overwhelmed by the cancer.
Now for our third suspect. This one's the trickiest of all. It's an inside job. It's an immune-mediated attack, where the body actually turns on itself.
Now with this suspect, the bone marrow factory is working just fine. It's pumping out platelets like it's supposed to. The problem is destruction. As soon as those new platelets hit the bloodstream, the immune system mistakenly tags them as foreign invaders and just wipes them out. And this gives us our key clue: a severe, and isolated drop in platelets while all the other cell counts look totally normal. And the definitive proof? These patients often respond incredibly fast to treatments that calm down the immune system, like steroids or IVIG, intravenous immunoglobulin. Now, look at this case file. It's such a stark contrast to the others. The platelet count is dangerously low, down at 12,000, but look, the other cell lines are completely normal. That severe isolated drop points the finger directly at an immune cause. This isn't a production problem, it's a destruction problem.
All right, so we've identified our main suspects, but knowing the cause, knowing who did it, is really only half the battle. The next critical step for us is to assess how much danger our patient is actually in.
So I have to ask you this: is that number, that single platelet count on the lab report, is that the full story? Is a patient who has 20,000 platelets always in the exact same amount of danger as another patient with 20,000? And the answer, maybe surprisingly, is a definite no.
See, to get the full picture, we have to look beyond just the count itself and consider 4 key factors. So yeah, the raw number, that's our starting point. But just as important is the cause of the low count, other things going on with the patient like a fever or an infection, and finally, what we have planned for them, any procedures coming up.
Okay, let's start with the basics. This table gives us a general guide. If you're above 50,000, the risk is pretty minimal. Once you dip below 20,000, we start to get worried about spontaneous bleeding. And below 10,000, well, that's when the risk of a life-threatening bleed becomes very, very real. But remember, this is just our starting point.
And this right here, this is probably the most important nuance of all. The cause completely changes the risk profile. Think about it this way. When there's marrow failure from chemo, the few platelets that are making it out are often old and they don't work very well. But in an immune case, the platelets being produced are young, they're big, they're healthy, they just get destroyed quickly. This means an ITP patient with a count of 20,000 might actually be at a lower bleeding risk than a chemo patient with the exact same count. This is absolutely the crucial takeaway. It is not just about quantity, it's about quality.
So once we have a handle on the real risk, we can turn to our action plan. The transfusion playbook. And this isn't about guesswork or gut feelings. This is about following clear, evidence-based guidelines for when we pull the trigger on a transfusion. If there is one number, just one, that you burn into your memory from this entire explainer, it is this one. Less than 10,000. That's the magic number. That is the critical threshold where we give a platelet transfusion even if the patient isn't bleeding at all. We do it simply to prevent a spontaneous, catastrophic event.
Now, of course, that 10,000 rule is for a stable patient who's just sitting in bed. If we're planning to do something invasive, the targets change dramatically. As you can see, for something like a central line, we might just need to get them above 20,000. But for a lumbar puncture or major surgery, we need that count way up, over 50,000 just to be safe. It really just proves that context is everything.
All right, we have cracked the case, and we've reviewed the playbook. So let's put it all together in one final briefing, just to make sure the logic is crystal clear for the very next patient you see.
So here it is, your 5-step algorithm. Step 1, always confirm the count is real and not just a lab error. Step 2, play detective. Is it chemo, marrow infiltration, or an immune attack? Step 3, assess the true bleeding risk using our 4 factors. Step 4, transfuse based on our playbook. But, and this is a big but, remember, in those immune cases, transfusions might not work very well because the new platelets just get destroyed right away. And finally, step 5, the most important one of all, treat the underlying cause.
So we'll end with this. The next time you are faced with that low platelet count on a lab report, what is the very first question you're going to ask yourself? It's not going to be, what's the number? It's going to be, what's the story? Because now you know exactly how to find the answer.